that the FDA category system has put all our psychotropic drugs under category C. So you have a lot of googling clients who would say कि ये सब दवाइयाँ बहुत खतरनाक हैं, you should not be prescribing. And as a young practitioner, 25 years ago, I also have made the same mistakes of stopping medication immediately when the mother is pregnant, not realizing what is the impact of stopping these medications on the patient. So, if you look at perinatal mental health in general, nearly 10 to 20% of pregnant women experience significant psychiatric issues. And these severe psychiatric conditions can obviously increase the risk of unplanned pregnancies. Unplanned pregnancies are obviously more stressful. And discontinuing medication during pregnancy can obviously worsen symptoms and lead to suicidal behavior. This is a very worrying part. Suicide in perinatal period is quite high, quite undetected. People don't come to know that she was depressed or psychotic, and that's the reason why she's committed suicide. Even non-psychotic mental disorders, they have been clinically been implicated to cause equal morbidity, whether it be anxiety disorder, whether it be depression, whether it be OCD, or even just stress. All of them can cause a lot of morbidity. So both the antepartum and also the postpartum period, you're also aware of postpartum psychosis, the most severe psychiatric emergency, which is very little discussed in the Western literature, but in our Indian scenario, I remember we have so many women of postpartum psychosis, which is such an emergency to manage, and during which infanticide and suicide rates are much, much higher. Even disorders like bipolar disorder, they relapse much more in the postpartum period. So you see, so much of morbidity is there due to these illnesses, and what would happen if you don't treat them? So just let's have a look at that part first. All of us need to be aware that untreated perinatal psychiatric illness has significant impact both on the mother, the family, and the fetus. And what is most worrying for me is this impact, what Alka had initially discussed. What is the risk to the fetus through fetal programming? I'll just give you a very important, I think this is one of very important slide which all of us need to be aware, that maternal stress, just a second, I'll just go back. Maternal stress, if you see, let it be due to stress, due to anxiety or depression or psychosis, any psychiatric illness, can have direct impact on the fetal programming. So much so that it can, in the long term, which was earlier highlighted, that in the postnatal period and later on also in the long term, this fetus will be more vulnerable to cardiovascular disorders, neurological diseases, and metabolic diseases. So it impacts the normal fetal tissues, organ development, leading to a whole range of disorders. So if you're not going to treat, imagine what is the impact. And I think this is one thing that you have to always keep in mind when you suddenly stop all medications, thinking you have done a great job by saving the patient from exposure to the drug. We had a very simplistic approach. Stop the drug, we had an omission bias. We have saved the patient from a teratogenic molecule. But no, if you're not treated, there are so many things that can happen to the baby. So is this drug really that harmful? A lot of research now has gone into this area also, which I will be discussing later. But let's have one very interesting review by Huberts in 2014. He found out that the infant outcomes with prenatal exposure to antidepressants. This is the largest database that he selected, sample size of more than 9 lakh women. And he found that there was no association between first trimester antidepressant exposure and cardiac malformations when the analysis was controlled for underlying illness, that is major depression. So what we were attributing to the drug probably is actually being caused by the illness itself. The mechanisms which are leading to psychiatric illnesses could well be contributing to all the malformations that we have been thinking, either structural or functional. So this has kind of changed our thinking process now. Because of the large sample size, these authors are able to compare the outcomes of women with depression who took antidepressants to the outcomes of women with depression who did not take antidepressants in the first trimester, thus controlling for the illness itself. Now, I lay a lot of importance to this fact because previously all the research was saying it is the drug which is causing these abnormalities. But when better techniques were used in these studies, and you have controlled them, you have compared apples with apples. You have taken a depressed mother and who was not received treatment, and one was received treatment, and they did not find higher risk of abnormalities. That is so important. So it just changes the whole scenario of our approach while treating. This finding, like I said, supports other studies that attempted to control for major depression and its associated behaviors and risk factors which do not find an association between in utero antidepressant exposure and cardiac defect, especially. You knew paroxetine. We were, always telling, I think the first guidelines that we had started making in a workshop 10 years ago was, don't use paroxetine. It can cause septal abnormality. We still nurture that thought though, because literature has, we don't have that much evidence to say it doesn't cause. But when they have started having such large observational data, then probably we have to have an absolutely different direction of thinking. Now again, this is another very important study of Wang et al., which performed a meta-analysis of prospective cohort studies. They found no association between SSRI use in first trimester and heart defects when comparing women with depression who took SSRIs and others who did not. So, the previously identified association between in utero antidepressant exposure and heart defects appears most likely to be associated with other risk factors and behaviors that are prevalent in population of women who are taking antidepressants. We know depressed mothers can be using alcohol, they can be using other substances, they might be having poor nutrition, they are being exposed to a whole range of environmental factors. When they are depressed, they are not taking good antenatal care, they are not going to their receiving folic acid, say even. So that all other factors could well be contributing to the malformations in the baby. Hubert's et al. Again, it's another very important study, nearly 3.8 million pregnancies with more than 1.28 lakh women who took antidepressants. Again, they found an odds ratio initially of 1.51 for an association between SSRI exposure and PPHN, which is a very, very important, very serious condition of pulmonary hypertension where the mortality is very high. But when they reanalyzed their data and they adjusted for the potential confounders, and they found that the odds ratio became insignificant. So the whole lot of literature that SSRIs can cause autism, they can cause heart defects, we have to really start thinking. Though I still must admit that we cannot fully confirmedly say this, but yes, there are a lot of grey areas and we have to start doing research in a very different direction now. Now, as practitioners, how do we approach and what knowledge we need to have when we are prescribing psychotropics, especially considering the fact that literature has shown that they are all FDA C category drugs. We need to be aware that in pregnancy, there are a lot of maternal adaptation that goes on because of change in pharmacokinetics. You may need a lot of dose adjustments due to this, because you see, during pregnancy, there's a sudden raise of estrogen and progesterone, and this rise in progesterone causes delay in gastric emptying and intestinal transit time, which can affect the medication absorption. So there is a slower absorption, and due to which you may not get the same effect of the medication when you're giving it when she's not pregnant. Similarly, there are changes in the plasma volume and tissue composition that can alter the distribution of lipophilic medications. Now, as you know, all our psychotropic drugs are lipophilic. And when the plasma volume increases during pregnancy, obviously the levels are coming down. And what we try to do in our clinical practices, she's pregnant, try to give the lowest dose. And we generally prescribe it at a lesser milligram, thinking that we are doing, we are being safe. But that's not the case, because the levels are dropping down, and for the same therapeutic response, you may require higher doses. Similarly, hepatic metabolism is affected by increased enzymatic activity due to the hormonal changes, and similarly, renal clearance is also increased because of the increase of glomerular filtration rate. So like say for lithium, the GF, we would say use lithium at a lower dose, but you require higher doses because the GFR has increased so much during pregnancy. Now, what is the pharmacokinetics of the fetus and the neonate? Now, this modified maternal drug pharmacokinetics in combination with placental transfer will actually determine the fetal psychotropic exposure. Like I had mentioned, most of the psychotropic drugs are lipophilic. and they will cross very fast through the placenta to the fetus. The other important factor which decides which medicine will go more is the pH gradient across the placenta and the drug's protein binding characteristics. So the drugs which are more protein bound, they are less likely to cause side effects. So that's one reason, why most practitioners in the West have started using sertraline or Q-typin more, because they are more protein bound and the chance of their going to the placenta is much more lesser. So these are the factors that we need to keep in mind. Like I already mentioned, that are they highly lipophilic, and what is worrying for us is the permeability of the fetal blood-brain barrier is very high in the fetus, and the immature central nervous system generally appears to be more sensitive to drug effects during this time. So we have to use the lowest efficacious dose for this reason. You use a dose, I'm not saying it should be subtherapeutic, but it should be adequate. At the same time, don't over-medicate because you may harm the fetus due to these drugs. The hepatic mechanisms of the fetus are also not mature. So it leading to reduced rate of drug metabolism and increased drug accumulation in the fetal compartment. The fetus is not mature enough to metabolize that exposure. Especially in the late stages and the first 3 months of life, it's very important for us to be aware that the metabolic capacity is very low, and hence we should not be unnecessarily exposing to high quantities of the drug. So as clinicians, always try to use the lowest efficacious dose, a therapeutic one, to avoid more damage. Now, another very important area which we have not implemented in our developing countries is the concept of therapeutic drug monitoring. In the West, it has become an integral part of standard of care, because therapeutic drug monitoring is one way where you can optimize the dose and you can be sure that this is the right dose to be used. But we know it's not easily available. Of course, for lithium we do have, but it can be used for all drugs so that we can have a least exposure of the baby to the medications. Now, in cases of polypharmacy, we know in our most of our prescriptions, we are using a combination of drugs. We are using anxiolytics along with antidepressants. So we don't, and the mother may also be taking drugs for diabetes or hypertension during pregnancy. TDM is a very valuable tool to avoid adverse effects. We also need to be aware that there are some mothers who might be metabolizing the drug very rapidly, and there are some who might be slow metabolizers. Now this is genetically, kind of found out that there are some who are ultra rapid metabolizers, some are slow. Though we don't have those genetic tests, but you have to be aware of these factors while prescribing. The previous data, we knew that in the first trimester, this is the most sensitive period where structural teratogenicity can occur. Paroxetine was most implicated, but current research is not as high as it was previously thought, but yes, it does increase the risk of heart effects. So we can be cautious for using. With lithium, we all know the effect of impact leading to Epstein's anomaly, and we are very worried, especially during the breastfeeding period, to use lithium. Valproic acid, one of the drugs which has been most neurotoxic, it has in fact had been banned in France. Countries like France say don't use valproate at all in reproductive females because it can nearly cause 30 to 80 times risk of neural tube side effects and other cognitive deficits. Similarly for carbamazepine, and there is some literature for venlafaxine as well. But like I said, these are very small studies, and we have, what I have told you previously, keep in mind that the illness also can be contributing. So you really need to draw the right balance. Now coming on to use of benzodiazepines, try as much as possible to withdraw benzodiazepines gradually in patients who are already on benzodiazepines, especially the ones who are in combination with SSRIs. Because it has been found that when excessive dose of benzodiazepine exposure is there, it may lead to excessive sedation and respiratory depression in the baby. Now SSRIs, we also had a lot of literature earlier that baby might have withdrawal symptoms, especially in about 30% of them have, but they are mild, they subside on their own. But the worrying part was PPH, like I mentioned. But then PPH, whether SSRIs alone are responsible, now newer research data is saying SSRIs probably are not responsible for PPH, and there are other factors which may be implicated. So how should we do exactly when we are actually coming into the field of prescribing? Before beginning any medication, I'm just using antidepressant as an example, always counsel the patient. No decision regarding use is perfectly risk-free. There is exposure to illness, there is exposure to drug. But how severe is the illness and why you need to treat it, that you should always be able to explain to the patient properly. SSRIs are the most best studied class of medications. Most birth registries in Europe, especially and in Scandinavian countries, they have had birth registries where they have used large databases, and they have said that they are quite safe to use when required. Encourage non-medication treatments. If she has mild disorders, you can use psychotherapy. She's being pressurized, like somebody said, to have a male child. There's so many other factors coming into play, and IPT could be well used during this time. And of course, CBT also is a very good mode of therapy if the depression is mild and too moderate, and the family doesn't want to use medications due to the risks involved. So if pregnant, benefits of taking an antidepressant actually quite outweigh the chance of relapse. So if you are going to prevent a relapse, it's better to use. In lactation, luckily for us, all antidepressants are quite safe. In fact, though they were telling that it's category C drug, but in breastfeeding, the amount of drug which is actually reaching to the fetuses, to the baby, is much lower. And I'll discuss about it later, the concept of RID, that is relative infant dose. And most of our drugs that way are quite safe. So this I had already mentioned, that if you don't undertreat, you are increasing the risk of postpartum depression and birth complication. You may prevent bonding, and studies are now saying that evidence does not suggest long-term behavioral changes in children, and even the neonatal symptoms are much lesser. So SSRIs are much safer than previously thought. Now coming on a mood stabilizer, so-called groups of medications which you use to stabilize the mood. Lithium. It was absolutely, we used to say, don't use lithium at all because of the risk of teratogenicity. So we were, if a patient of bipolar disorder used to come, the first thing, my God, lithium hai, bilkul nahi dena hai. And first trimester, obviously we were not using. But in case of severe bipolar disorder, where the risk of suicide is so high and you have the severity of the illness is so worrying for us, many of the other molecules are not that efficacious and you have to use lithium. And there lies the clinical skill, how you communicate with the family, what are the risks involved. Most of the time our mothers and families say, मुझको कुछ हो जाए नहीं फर्क पड़ता, but मेरे बच्चे को कुछ ना हो. So please, lithium तो हमने इतना पढ़ा है, हमको बिल्कुल नहीं use करना है. And I think one of my seniors had a real case study where he informed that he stopped lithium and the lady committed suicide. And that was so troublesome for him because he all the time felt guilty. I did not explain the risk of suicide due to this illness to the husband and the family well, or to the patient, so that she would have taken a better decision. So how you get an informed consent and how you communicate the risk of the illness is so important, and sometimes it's so difficult, the kind of ethical dilemma that we have when we use these molecules. Lamotrigine again is one of the safer mood stabilizers, but unfortunately it's not very good in mania. In bipolar depression, we have data to show it is effective, but not very good when you have a manic episode. But then yes, it is one of the safer molecules. Valproate, we have got good it's an efficacious molecule, but unfortunately, because of its neurotoxic side effects, unless, I had one of my professors saying, you have an epileptic patient who is responding only to valproate. So better take a consent that these are the risks involved. You have to go for an annually screening and go for a fetal echocardiography well in time, so that, if the drug has caused side effects, you terminate the pregnancy. So all these options are there. Now, the other group of drugs which we have started using now in bipolar disorder are the typical first generation antipsychotics like haloperidol, trifluoperazine, and the atypical ones like quetiapine, aripiprazole, and olanzapine. The first generation psychotics, our seniors would say, lot of data was there to say they are safe. But because of risk of EPS, we were not using it. The baby might have tardiness movements. So we are now preferring SGAs. But the problem with SGAs, we all are aware, is the chances of their causing fetal weight gain, obesity, leading to diabetes. So again, SGAs are also giving us this problem when we are using, but then you have to balance so many factors which have to always be kept in mind. So like lithium, I said it was a gold standard molecule for bipolar disorder. It reduces suicidality, but then we are not very sure if the family would agree to that increased risk of congenital malformations. You see, earlier the research said that lithium causes 1 in 1,000 was the rate for fetal abnormalities. Now when current research is going on, they say it is lesser. Because when they're cutting out the confounding factors, probably it is not so toxic as it was previously, which I had already informed. So you may use lithium, but always take the consent of the patient and always go for a screening for an anomaly scan and fetal echocardiography in good time, say around 18 to 20 weeks, and again initially at 10 to 12 weeks and then 18 to 22 weeks. Now, like I had already mentioned, that lamotrigine STs, I think I have already mentioned, so I will not repeat this to save time. But let me go on to what you do when you have a patient who is already psychotic and who have had history of psychosis in the past. Always remember, psychosis is a very big issue because if the mother becomes very disorganized, the chances of her having an abortion is very high. So you need to plan these pregnancies for women who are psychotic. Always advise them that, if you're planning a pregnancy, please inform us. And she should be maintained on the antipsychotic that she was responding to. Many a times, people say, "Abhi to theek hai, band kar do dawa." But if she relapses, then it's a very big problem. So always keep that in mind. So best maintained on the antipsychotic that you were using. And because a risk of relapse is also a risk of exposure. So this may minimize fetal exposure, avoiding the need for a higher dose should a relapse occur. Now, if the patient is established on another antipsychotic, usually they have a tendency, देखो ये वाली drug ज़्यादा safe है, so let's switch over to this medication. But it is wiser if you have known this patient for a good time to use a molecule which she has responded to. It is much safer to do that rather than going, with this mind in our mind that this might be safer and that might not be safer. Use first generation or SGA. If she has responded to haloperidol, say, for example, she was well maintained on a low dose or say low dose of trifluperazine, and you think, let me shift to an SGA, it could be safer. You are running the risk of a relapse. Try to avoid that double exposure. Now coming on to breastfeeding. Postnatally, you see, WHO has always recommended that encourage breastfeeding. Previously, we used to think a mother who is exposed to a drug, the child will be exposed to the drug, so stop breastfeeding. And families also nurture that thought permanently. Breastfeeding nahi dena hai, dawa chal raha hai. But of late, the current trend is to promote breastfeeding. Because it promotes bonding. And the amount of medication that goes actually to the fetus is much lesser, except for molecules like lithium or doxepine. Rest, all our psychotropics are safe in breastfeeding, the current research says. So, except for, and of course, you should not encourage breastfeeding if the baby is premature. Because then even a small amount of drug can cause harm to the baby. Then another problem that we sometimes see is severe psychiatric illnesses like bipolar disorder, where sleep deprivation due to continuous disturbance of sleep by the baby demanding feed, the mother might go in for a relapse due to sleep disruption. In such cases, we do say, breast, milk ko pump kar lo, and then, let the mother-in-law or other caregiver feed the baby rather than the mother. So always, even then, we still follow the rule that use the medications with lowest known risk, and the guide that has been, what I had mentioned about the relative infant dose, this is the most factor importantly used. It's the ratio of the maternal and the infant drug level. It's this ratio if it's less than 10, and luckily for us all drugs are less than 10, most of them, so we can encourage breastfeeding. Now to sum up, I would say, what are the common errors that we do? We generally stop all psychotropic medications. Most of us did this mistake. Don't do that. Don't underestimate the risk of psychiatric illness in pregnancy. Undertreating the psychiatric illness can lead to another exposure, rather a double exposure. And if you're stopping benzodiazepines, please do it slowly. Don't do it fast because it causes a lot of increase in anxiety to the mother and sleep disturbance, which could be problematic. And we don't address the issue of substance use cessation. Many of our mothers are abusing alcohol and tobacco, which we are not aware of. But so we should address this issue also. And many of us think all antipsychotics are FDAC category, so even if she's psychotic, we have to do some other measures. That's not very sensible. and avoiding use of lithium in severely ill mothers. You can use cautiously. And of course, prescribing valproate and carbamazepine in reproductive age group without a contraception plan or a plan for medication management during pregnancy. If you're using these molecules, advise contraception. If you're not responding only to this, you can even say delay your pregnancy, will gradually withdraw the drug when you plan a pregnancy. But unfortunately in India, actually, most of our pregnancies are unplanned and we don't have these privileges. Another new scenario of, I'll just say if we have time, that we have now another group of women who are reporting to us, especially with infertility. Now, and they're wanting to conceive, they're quite anxious and depressed. And my obstetrician would always say, "Sab dawaiyan band kar do, this is a high risk pregnancy, special case hai, we have to give IVF, koi dawa nahi chalni chahiye, and she should be, protected." But what we have noticed is that the severity of anxiety and depression in these mothers is so high that if you don't treat, they really don't, the IVF is a total failure. And once you treat, especially with safer molecules like SSRIs, we are getting dramatic results. I mean, I would like to share my own medical officer. She was so stressed out that she was not conceiving. And when we followed the treatment regimen well, just before IVF, because her mood was better, she conceived naturally. So that was a big boon for us, and I learned from that address these issues. Do address the social aspect, especially if she has a lack of social support system, because we know that a lack of perceived social support in our families is a tremendous stress, both for the urban and the rural population. So always keep these issues in mind, treat them, don't be worried. And if you want to go about monitoring these mother, how severe is her depression, continuously monitor her depression. And you can always use psychotherapy, of course, if you have social stressors, and then discuss the risks and benefits of treatment. Abrupt discussion, like I said, must be avoided. Folic acid giving is one of the standard practices now. I make it a point to give at least 5 milligram per day who are planning pregnancy also, so that you don't have this problem. So then, I think we are just crossing. So I'll just end up with a very important fact that you should always screen the patients early for disorders. And one treat this FDA category has created a lot of ruckus because this classificative system is not actually foolproof. It generates a misperception that the letters reflect an increasing risk when actually it is risk balance. So you say A hai, ye B hai, ye C hai, D hai, D1 to bilkul nahi, C1 hai bilkul nahi. That's kind of when people go through Google, they get quite carried away. So a newer system is now being established in 2015, which is called the PLLR, which discusses the risk summary, the clinical considerations, and what are the therapeutic alternatives and data summary of each drug. This is a very complex process though, and because the birth registry is now being established in Europe, we are able to implement this system by the other Western corporate. Though in India we still don't have a birth registry, and I regret that in perinatal psychiatry we really need to start one. Now a new molecule, I'll just touch on this, which is really a miracle kind of a drug that suddenly has come which has been used in postpartum depression. It is called brexanolone. It's a allopregnol synthetic derivative, which is working it's a neurosteroid and it's allosteric GABA A modulator. This drug is improving depression very fast. They're giving an infusion and the impact is so quick, unlike SSRIs which take about 20 days to show effect. In postpartum depression, it has shown dramatic results in US, but it is not yet available in India. So who knows, we might have better drugs in the future. The oral part of this medication is also being marketed now in the West. Again, not available in India, but this is a little boon. So to end up, we need to follow certain 6 rules, which I think is a little too complex slide, but very simple rules. All changes of drugs should be carried out before pregnancy if possible. Ideally, the patient should be psychiatrically stable at least 3 months before trying to get pregnant. Use the...
Thank you, ma'am, for such a wonderful presentation. And with this,
see, how do we approach patients who need benzodiazepines during their pregnancy?
See, I think if you give them a gradual tapering, it is always better. Reassurance. And you can use, suppose if mother is anxious, always find out is it an endogenous anxiety or the external factors which are coming into play. not addressing those issues are equally important. You know, the psychological dependence of the drug can, if you tell, if you're going to take 3, then you're going to take 2, then you're going to be 1, we'll manage rest by relaxation techniques. Our psychologists address these issues by which, in fact, when a patient comes with panic attacks also, we always use our psychologist's help to teach her how to relax through this panic attack by simple breathing exercise also. So you can use these measures. Though I know it is a challenge, it's not so easy, but try tapering it gradually.
So pharmacologically, what do you replace in case if nothing else works non-pharmacologically?
See, I think most of us are using SSRIs or other antidepressants. Those have to be continued. Don't stop them. It is very rare that we use only benzodiazepines for anxiety disorders. The neurotropic drugs, such as venlafaxine or sertraline or citalopram, please continue that. You don't have to stop that. You have to target that main molecule which is going to work. And this you can, in fact, at the starting itself, I always say that when you're prescribing, use a safer drug, use the lower dose. If you're wanting to add benzodiazepines, withdraw them within 15 days. We don't do that generally. I think even I made that mistake. She's very happy settling with that SSRI combination, say, Lexapro plus escitalopram with clonazepam. We have not bothered to withdraw it in time. So that's an important part of our practice, that we should withdraw the benzodiazepine before itself, so that she doesn't.